So we have come a long way in the field of myeloma, developing many new drugs in close collaboration with pharma and biotech. Many new drugs have come, and there are so many drugs coming. It's just amazing to see how the field is changing. But at the same time, unfortunately, the majority of our patients, they seem to continue to relapse. I want to say that I have patients, many patients I followed for over 10 years. They are sustained MRD negativity, and they are off therapy at their own discretion, or they stay on a low intensity maintenance, say lenalidomide, at their own discretion. They can choose to go off if that's what they decide to do. And many of those patients I followed have not relapsed. So I do think myeloma is a disease that can be cured. But what we don't have information on at this point is who is that patient when the patient is newly diagnosed. You have 100 patients, you don't know who those patients are. So the majority of patients will unfortunately relapse. So when we follow and track patients after combination therapy with or without transplant, unfortunately, patients will suffer from relapse. The average patient treated with modern combination therapy these days, with or without transplant, probably could last, I would say, 5 to 10 years, 5 to 8 years, something like that, without having progression events. About 10% or so of patients, unfortunately, would have a relapse within 6 to 12 months. And they have a very different disease biology. And I was talking about before our model using the integration of whole genome or whole exome data for genetic profiling, integrated with clinical outcomes, and also with treatment details, exactly which drugs. That's exactly where these databases are very helpful, because if you can understand the biology, if you can identify clusters of genes that are involved in these unfortunate patients that progress early on, that would potentially give us clues on how to design new treatments. There should be completely other drugs. There are new targets we could come up with and use them in combination with other existing combinations. And if that works, then we could kind of check off that box for a subset in that group. And if it doesn't work, then we have to go back again and we have to try. So I think we will have to develop more and more precision medicine to avoid, in particular, the early relapses. That is going to be, in my opinion, a top priority for the field. Precision medicine has to come to myeloma. It's time to do that now in this group of patients in high-risk diseases, but also long-term for patients who continue to relapse. We also need to develop drugs in a more traditional way, if you want, where we have access to more and more drugs so we can keep our patients alive and with good quality of life so they can live very long lives. And the last thing I want to say is that I thought about this a lot. I think that the field is at the tipping point. I remember when I was in med school, HIV was a new kind of phenomena, and there were patients who were diagnosed and developed AIDS, and there was nothing that could be done. These days, people with HIV have the same lifespan as the general population. That's a major achievement for the medical field. And I do think that myeloma is about to enter that same phase. So I think with all the drugs we have now, all the immunotherapy drugs that are coming, I think that the majority of patients, say 70 years or older, maybe eventually will have the same lifespan, but they just have to take drugs. And I hope that we will be able to do that for someone who is younger also. We really spend a lot of time focusing on trying to develop curative treatment. So that's another top priority.